Hello, and thank you for taking the time today to view this information on providing hospice care in the long-term care setting. My name is Julie Sampson, Director of Hospice at Prairie Lakes Healthcare System in Watertown, South Dakota. Today, I am providing general hospice care education for any long-term care setting. The care that we provide to our residents is very special work, and I hope that you realize how very valuable you are. When you think of hospice, what words come to mind? I often hear care providers answer with words like comfort, quality, and end of life, which are all very good and accurate answers. If we look at some of the published descriptions of hospice, you will see that hospice is a philosophy of care providing physical, mental, emotional, and spiritual care sharply focused on comfort and quality of life for people who are expected to live 6 months or less. Hospice is active care for people nearing the end of life whose illness is no longer responsive to curative treatment. Hospice care aims to manage the patient's symptoms while supporting their quality of life and providing support for family and caregivers too. Hospice helps to make the unfamiliar territory of death more comfortable and manageable. Hospice is provided primarily where a person lives, at home or in a nursing home or community living arrangement, so the patient can be near family, friends, and valued possessions. Hospice care does not hasten death. Instead, it focuses on providing comfort at the end of life and supporting the dying person and the family and the caregivers. All of these descriptions speak to comfort, quality, and end of life. So, the care provider's answers were right on target. So how did the idea of hospice begin? In 1948, a lady by the name of Dame Cicely Saunders, an English nurse, social worker, physician, and writer, started the first hospice in London, emphasizing the importance of palliative care in modern medicine and opposing legislation of voluntary euthanasia. In 1963, Dame Saunders introduced the idea of specialized care for the dying to the United States during a visit to Yale University, where she gave a lecture on pain management in cancer patients. In 1974, the first U.S. hospice was established in Branford, Connecticut. And in 1982, the United States Congress initiated the Medicare hospice benefit, which continues today. Think for a moment and consider your own death. What would you want that to look like? What would the best possible earthly ending mean for you? The responses I often hear to that question are words like pain-free, without suffering, and surrounded by the people I love. So how can this be fulfilled? The following list provides a good start to fulfilling those goals. Face fears about dying. Control physical pain, symptoms, and side effects of medications. Live fully, with quality until death from the disease, while maintaining hope and dignity and being treated with respect. Have open communication that is truthful, yet sensitive. Be heard and realize wishes and goals. Be emotionally and spiritually supported. Minimize stress for loved ones through family and caregiver education and involvement in care planning. To further define what hospice is and what it isn't, let's review some of the common myths and misconceptions about hospice. The first myth that I'd like to discuss is that hospice is for the very end of life. In reality, earlier is better. Hospice is most beneficial when there is sufficient time to manage symptoms and establish a trusting relationship. Earlier referrals allow patients to receive the full benefits and advantages of hospice. Manage symptoms earlier, stay stable longer, more fully enjoy life and activities. Also take advantage of the entire team, including the social worker, spiritual care, hospice aides, and volunteers. Adequate symptom management can occur, which allows patients to reflect on life, allows quality of time with family and loved ones, and allows patients to make the most of every day. Hospice can help prevent a pain crisis or respiratory distress at the end of life. So, earlier is better. We don't want residents to be in distress or in a crisis before seeking hospice involvement. The second myth is that hospice is just about dying. In reality, hospice helps patients to live. The focus of hospice is on helping patients live. While end-of-life issues are discussed, the focus is on helping address issues, concerns, or fears. Staff get to know the patient as a person, their preferences, hopes, qualities, and interests. Hospice patients are encouraged to fully embrace life during this journey. Hospice urges patients to make their goals a reality. I have heard many stories of hospice patients making goals reality. Some just want to plant their garden. Others want to attend a grandchild's wedding. Goals can even be as big as taking a bucket list trip to Texas to hunt for wild hogs. This was a goal from one of our hospice patients. After his symptoms were under control, he and his sons and some friends were able to fulfill this goal. So together, we certainly can make these goals a reality. Another myth is that hospice means giving up hope. The letters of the word hope are in hospice. People who choose hospice are not giving up hope, they're redefining it. Hope to live well all the days you've been given, and when the time comes, hope to die well with comfort and dignity. Research shows people on hospice actually live longer than those without hospice. With proper symptom management, patients often stabilize and have improved quality of life. And some even do so well that they are able to discharge from hospice. So as you can see, hospice focuses on providing quality of life. Myth number 4 is there are strict limits for hospice services. In reality, there really are no limits for hospice services, but the following are necessary to begin hospice care. The individual must accept palliative or comfort care rather than aggressive treatment, such as chemotherapy, diagnostic testing, or surgical intervention. Hospice must be ordered by a physician and is provided under the direction of the patient's chosen physician. The physician, along with the hospital medical director, must also certify that the patient has a life expectancy of 6 months or less. If a patient lives beyond 6 months, the patient may remain on hospice care as long as the physician can certify again that they don't expect the patient to live longer than another 6 months. I know of patients who have qualified for and received hospice services for well over a year. And finally, a patient must have a 24-hour caregiver established as they enter the very end of life. The staff at the skilled nursing facility can fill this role. The final myth that I would like to dispel is that hospice care is very expensive. In reality, traditionally, Medicare and Medicaid beneficiaries pay little or nothing for hospice care. Many insurances cover hospice care, and VA-eligible patients can be covered through the VA. All medications, supplies, and equipment needed to manage the terminal diagnoses are covered by hospice. Room and board in a long-term care facility remains the responsibility of the resident while on hospice, unless the resident is eligible for VA benefits, where room and board are covered, or when Medicaid is paying for room and board. Even without insurance, most hospice agencies will not turn anyone away because of the ability to pay. So, at what point should someone be considered for hospice care? Here are some signs and symptoms for hospice referral. If one or more of these are present, hospice may be appropriate. 10% weight loss in the last 4 to 6 months. Disease is life-limiting, 6 months or less. A new onset of incontinence, declining functional status, decreased cognitive ability, frequent hospitalizations for unmanaged symptoms, or the resident or family wants comfort care and decline all aggressive curative cares. If you notice residents with a number of these signs and symptoms, they may be appropriate for a referral to hospice. Often people think that hospice is only for cancer patients, but there are so many other end-stage diseases that are appropriate for hospice care, especially if symptoms are difficult to manage. These diagnoses include Alzheimer's disease, renal disease, heart or cardiac disease, pulmonary disease, cancer, stroke, liver disease, ALS, Parkinson's, multiple sclerosis, or any other end-stage disease. The hospice conversation should be handled with care, as everyone responds to the idea of hospice differently. Ask these questions so that you can better understand how to move forward with the conversation. Ask, what is your understanding of the situation and the potential outcomes? Find out if the doctor or other health professional has spoken to the resident and family about the prognosis. Do they know the graveness of their condition? Then listen. Be supportive but not domineering. Ask, what are your fears and what are your hopes? What are the trade-offs you are willing to make and not to make? Do you want to continue treatments and seek diagnostics? Do you want to continue to go to the emergency room for your terminal condition? What is the course of action that best serves this understanding? Once we know the course of action, it's important to hold these crucial conversations and discuss life care planning, because end-of-life conversations can be the most helpful and meaningful conversations you have. The resident has a right to comprehensive, quality care at the end of life. They may need guidance and information, but they are in charge of setting life goals. If the resident is no longer able to be in charge, follow advance directives or the wishes of patient's designated agent. Decisions are most complicated if end-of-life preferences have not been expressed. These conversations really help to prepare the resident and family so they have the best end-of-life care. Along with life care planning conversations, the hospice agency and the long-term care facility collaborate and develop a joint plan of care. In that joint plan of care, the hospice and the facility responsibilities should be delineated. General hospice responsibilities include evaluating hospice criteria and admitting to hospice, assessing and managing symptoms, maintenance of adequate medication, durable medical equipment, and supplies related to the terminal diagnosis. Approval of special services, such as therapy, treatments, or emergency services. Provision of interdisciplinary hospice services, including availability of an RN 24 hours a day, 7 days a week. Communication with the facility regarding needs for medication refills, new medications, supplies, etc. And then finally, physician on-call coordination, including orders. And then, facility responsibilities include provision of room and board services, 24-hour care per usual and customary services of the facility, coordination and cooperation with hospice staff in implementing and updating of the joint plan of care, administration of prescribed medication and treatments, as for all other residents, notifying hospice of a change in the resident's condition, uncontrolled symptoms, or any resident or family distress. Communication with the hospice RN regarding needs for medication refills, new medications, supplies, or other special needs. As stated in both the hospice and facility responsibilities, good communication is important. And then, of course, collaborative effort to provide the best in care is crucial. So there are joint responsibilities, which can include, again, the development and implementation and delivery of the joint plan of care, modification of the joint plan of care, ongoing communication and collaboration between the facility staff and the hospice staff, also quality assurance, ongoing integrated assessment of the quality and appropriateness of services provided to the residents. And then, of course, we have to document the services. Now, let's take a look at the hospice team. What do they do and who are they? Patient and family education is a big part of hospice care. The team will address educational needs such as the following. Discuss the emotional impact. How is everyone doing? Discuss medication and comfort measures. Educate on caring for the patient. Disease process. Discuss food and hydration. Assess and explain symptom management. Explain sign and symptoms of dying, and also discuss end-of-life arrangements. Each hospice has an interdisciplinary team, or IDT, which includes a medical director, physicians, nurses, social workers, hospice aides, and spiritual care staff. The IDT meets every 2 weeks to review all patients and address any concerns in the patient's plan of care. The medical director oversees the medical aspects of the hospice care and certifies eligibility for hospice. The primary physician is chosen by the patient to direct his or her hospice care. Nurses provide education to patients and families, coordinate the care, and provide for the physical comfort and overall well-being of the hospice patient. The medical social worker provides counseling and emotional support for the patient and family. The social worker will identify additional resources in the community and serves as the patient's advocate. Specially trained hospice aides are also available to assist with bathing and personal cares in the nursing facility, often doing so in addition to the scheduled bathing and personal cares provided by the nursing facility staff. These hospice aides can provide care on an intermittent basis up to daily if needed. The spiritual care team members support the patient spiritually. They do not replace the patient's own pastor or spiritual director. They do help the patient to find spiritual peace and comfort. In addition to spiritual support during the hospice journey, grief and bereavement support is provided to the family and loved ones for a year after the patient's death. These can include grief support group meetings, memorial services, mailings on anniversaries and special dates, and one-on-one phone calls and support. The spiritual care staff can also make referrals to professional counseling if that is needed. Volunteers are also part of the hospice team and are trained in hospice care. They are matched to the patient and family and are scheduled per patient and family need. Then, as I mentioned previously, Medicare and most insurances pay for all medications related to the patient's terminal diagnosis. And durable medical equipment that the nursing facility may not have is also provided through hospice. So, what doesn't hospice provide? Unless a patient is in an inpatient facility or hospice house, 24-hour care is not provided by hospice. So then family is responsible for care when a patient is no longer able or safe to care for themselves in their home or in most assisted living facilities. In the skilled nursing facility, staff are able to serve as the 24-hour caregiver. Hospice does not cover most medical or diagnostic tests, curative treatment, non-essential equipment, or long-term medications that are not related to the terminal diagnosis. Now that we know what hospice is, who is on the team, and what services are provided, how do we provide this comfort that is the heart of hospice? Together, the hospice team and the long-term care staff provide the best in comfort. Let's first take a look at some common end-of-life symptoms to better understand what comfort measures to use to alleviate these symptoms. Pain of varying types and degrees, shortness of breath, otherwise known as dyspnea, depression, anxiety, agitation, restlessness, fatigue or tiredness and sleepiness, mental confusion, constipation or incontinence, nausea and vomiting, or anorexia. Each of these symptoms alone may not immediately indicate that someone is dying, but for someone with a serious illness or declining health, these might suggest that a person is nearing the end of life. A very significant part of hospice care is managing pain. To manage pain, a comprehensive assessment must be completed to identify root causes of pain. Then we must develop the plan of care and then, of course, monitor that plan of care. Because pain robs us of quality of life, hospice nurses are experienced in identifying types of pain. They understand the medications that are most effective in treating varying types of pain, ultimately giving back quality of life. Pain can affect mood. The patient may be short-tempered, angry, or irritable, which not only adds to discomfort, it also makes it very hard to share thoughts and feelings. Experts believe that caring for someone who is dying should focus on relieving the pain without the worry about possible long-term problems or drug dependence. Pain is so much easier to prevent than to relieve, and overwhelming pain is hard to manage. Common experiences at the end of life are difficulty breathing and shortness of breath. The use of oxygen can provide relief as well as the use of narcotics. Nebulizer treatments may also be helpful, as well as raising the head of the bed or using a fan to circulate air in the room. Also, it is important to plan activities to conserve energy. Use a wheelchair if walking causes shortness of breath, or a commode if getting to the bathroom is too taxing. Terminal bubbling, or the death rattle, happens when fluids collect in the upper airway, making a wet, gurgling, rattling sound. This is usually not upsetting to the resident, but it can be upsetting to family and friends. So what you can do is turn the resident to the side. Medications that help dry secretions are also effective in managing this collection of fluids. We want to be sure to pay special attention to our resident's skin. Protect bony prominences such as elbows, shoulder blades, ankles, heels, and hips. Pillows can be used to offload pressure and support limbs. The use of an alternating pressure pad or an air mattress is an effective way to offload pressure as well. Be sure to keep skin clean and dry, as wet skin is more fragile and increases the chance of skin breakdown. A simple, gentle massage can provide much-needed relief and relaxation, and using lotion keeps skin soft. Repositioning every 2 hours is extremely important. This helps keep the blood flowing and prevents skin breakdown. This is also a good time to check the skin for redness. Digestive problems can also be a concern. Nausea and vomiting must be managed. It is important to identify the cause of the nausea. Could there be a bowel obstruction? Is this an adverse effect of treatments or chemotherapy? Or is it simply the disease process? Finding the root cause will help to determine which medications will be most effective. Overall loss of appetite is also a common complaint, but going without food and water at end of life is generally not painful, and eating can actually add to discomfort. Let the resident be in control of intake. Encourage family and caregivers not to force food or drink. This reminds me of a story of one hospice patient whose wife had made him a delicious carrot cake, adding extra calories and serving him a big slice so that he would gain some strength and nutrition. As much as he loved carrot cake, he told his wife, "You feel better when I eat, but I don't." Small, frequent meals might be tolerated the best. Listen to your resident. So when it comes to nutrition, what about feeding tubes and IVs? Is this allowed under hospice? Feeding tubes and IVs are allowed while on hospice, but when the body is shutting down, it requires less food and fluid to function. The body is not as able to process food and fluids as readily during this time, so using IVs and feeding tubes can cause the patient to become more restless and experience more discomfort. Some patients do trial tube feedings for a short time to see if it makes a positive difference, while understanding that the tube can be removed if there is no improvement in the quality of life. The following are benefits of not using a feeding tube or IV fluids. Less fluid in the lungs and therefore less congestion, making breathing easier. Less fluid in the throat, thus less need for suctioning or medications to dry secretions. Less pressure around tumors and therefore less pain. Less fluid retention in tissues, decreasing the risk of pressure ulcers. Refusing food might be a conscious decision, a part of the dying person's understanding that death is near. If the patient doesn't want to eat, those wishes should be upheld and respected by the caregivers. So, if the resident isn't eating or drinking and they don't have a feeding tube or IVs, won't they become dehydrated? At the end of life, the body does become dehydrated, which can actually cause a natural release of pain-relieving chemicals. Some describe this state as a mild euphoria. Symptoms of dry mouth and the sense of thirst can both be relieved by swabbing the mouth, good mouth cares, ice chips, or sips of water if tolerated. Never withhold food or fluids, but let the resident decide how much, when, and if they eat or drink. So what about constipation and incontinence? If a resident is on narcotics, a common side effect is constipation, and inactivity can also lead to constipation. So it is very important to have a bowel regimen including stool softeners and laxatives such as Miralax or milk of magnesia. And of course, with incontinence, cleanliness and changing incontinence pads as soon as they are soiled is important to prevent skin breakdown. A catheter can also be used if skin breakdown, urgency, or frequency is a problem. Let's look at temperature sensitivity and fatigue. With regard to temperature sensitivity, residents can't always tell you if they are too hot or too cold. Watch for clues. If they are trying to remove a blanket, help them, or try a cool cloth to the forehead. If shivering or hunching their shoulders, obviously cover them with a blanket. Then fatigue is another frequent complaint. To help combat fatigue, use a commode if they are unable to walk to the bathroom. Use a shower chair to shower or give a bed bath. Plan activities carefully. Conserve energy. Use that wheelchair. Work with residents and families and visitors to ensure that the resident is getting adequate rest. If a sign needs to be posted on the resident's door to limit visits, it's okay to do that. It wouldn't seem a surprise that depression is common for those facing a terminal illness, and that patients may benefit from antidepressants. Moods can and should be elevated if possible, and antidepressants can be effective. There is a difference between sadness and depression, and individuals may actually experience both. The symptoms of depression can include disturbed sleep, anorexia, weariness, and the inability to enjoy their favorite things. In addition to depression, anxiety can also be a concern. Here are some questions and ideas that can help to alleviate anxiety. Have a heart-to-heart talk with the resident. Are there specific fears? Have they suffered from anxiety in the past? Are they adapting to their life changes and terminal condition? Get to the heart of their fears. Inadequate denial can also cause anxiety. Rather than avoiding talking about the person's illness, discussing it can reduce anxiety. Careful explanations can be so helpful. A burden shared with another lightens the burden carried. Agitation can occur, as well as what is referred to as terminal restlessness. It is again important to determine the root cause of the restlessness. Is it physical discomfort, such as pain, constipation, urinary retention? If so, address the physical discomfort. Then, create a calm and comfortable environment. Reduce stimuli, play soft, soothing music, and provide familiar objects. Provide reassurance and communication. Use a calm, reassuring voice. Use gentle touch. Listen actively, and gently remind them of who you are. Be sure to involve the hospice team. Keep the hospice nurse informed, and together review medications in the plan of care. Involve the social worker and spiritual care staff to address psychosocial and spiritual needs. And finally, what about treating infections? Is this allowed under hospice? Infections such as pneumonia or urinary tract infections can be common, and they can be treated, but they don't have to be. Visit with the resident and family regarding treatment for infections. If they occur, consider the following. Will treatment improve comfort and quality of life? Giving antibiotics is probably not going to prevent death, but might make the person feel more comfortable. The decision to treat an infection with antibiotics will depend on the circumstances of each case. And that completes our discussion of hospice care and the collaborative effort in long-term care. I hope you know what a privilege and honor it is to accompany our residents on their end-of-life journeys. Providing comfort and quality of life is very special work. The greatest gifts you can give are to listen carefully and then to provide for each individual need. Use touch and kindness. We are all indeed moving toward the end of life the moment we are born. Together, we can help others make their way on the journey toward the best possible ending. Thank you for watching.